There are four isoforms for pediatric: alpha, beta, gamma, and delta. And there are drugs that you can selectively target one or more than one of these isoforms. So idelalisib targets delta, duvelisib target gamma and delta, and you have now copanlisib target alpha and delta. There are other delta-specific inhibitors beyond idelalisib. And those drugs have, as I said, different safety profiles and different advantages. Right? The advantage of combining alpha and delta, at least from preclinical experiments, is at least twofold. One, if you inhibit one isoform, the other one may compensate for it. So you can still activate downstream events by having alpha still active. And in some cases where patients had repeat biopsies and you measured gamma and alpha levels, it seemed like at relapse, alpha levels goes up, and suggesting that there's maybe a compensatory mechanism through alpha. So again, in theory and from preclinical experiments, it seems that combining alpha-delta inhibition may be more effective upfront and may inhibit this feedback mechanism through activation or increased level of the alpha. That comes with some side effects because alpha inhibition can contribute to the hyperglycemia, which is usually seen in patients treated with pan-PI3 kinase inhibitors, and the transient hypertension that is also seen. So these are on-target effects, but they're transient. Just because you have hyperglycemia with these agents doesn't mean that you're going to have diabetes when you stop treatment. It's just transient, goes up and down depending on dose schedule that you use these agents. The potential for copanlisib and other PI3 kinase inhibitors in improving treatment outcome in follicular lymphomas and, in my opinion, in other lymphoid malignancies is combination. There's consistent data right now with idelalisib and copanlisib that the best response we can get is about 55–58% response rate. And most of these responses are partial responses, and I give you about a 1-year mileage. So the question is, how do you improve on that? And it's going to be through rational designed, mechanism-based combination strategies. So you'll see in the future multiple combinations with these PI3 kinase inhibitors in follicular lymphoma and other lymphoid malignancies.
There are several randomized phase 3 trials that have been conducted with copanlisib. There was the Chronos 2 trial, which was done all extra-US. And this was in rituximab refractory indolent lymphomas. They were randomized to copanlisib or placebo. Now, personally, I find that study design to be questionable, of treating somebody with a placebo when there are other drugs out there that might be of some clinical benefit. Not done in the US. There is the Chronos 3, which is in a similar population of patients, rituximab with or without copanlisib. That study is still ongoing. The first study I mentioned, Chronos 2, is closed to accrual. And then there's Chronos 4, which is bendamustine rituximab or R-CHOP with or without copanlisib for relapsed refractory follicular low-grade lymphomas. These are interesting studies. They're important for defining the role of this new PI3 kinase in our clinical panorama. With longer follow-up, that's when we're going to get a better idea of how the toxicities of this PI3K inhibitor stack up with idelalisib. Because as I mentioned, the itis may not occur for months and months down the road. In fact, I had a patient on idelalisib who didn't develop the colitis for 2.5 years. So you got to keep your eyes out. You can't be complacent in monitoring these patients. You have to actively investigate the toxicities. And hopefully we won't see them with copanlisib. Maybe the intravenous administration abrogates that problem, but time will tell with this drug. And hopefully it will provide additional benefit to patients with follicular and low-grade lymphomas.